دكتور نشوى, which
أيوة.
babies develop neurodevelopmental disabilities? The risky group. Okay, is the risk is related to the environmental factor and the NICU admission, or there is risk related to the baby itself?
Excellent, excellent question. So the risks actually, I will go back to what Professor Afef said. There is genetics and there is epigenetics. So the genetics is, we know that the most common a factor in outcome for developmental a outcome is maternal education, okay, and social class. So there are things that actually embedded in genetics that are increasing the risk for these babies, okay? The extreme prematurity, because their brain has been out of their a protective womb, so we know a lower gestation has a higher risk. Babies with some severe congenital heart disease, there's already has been a problem with before birth, before going into theater or being born or put on a ventilator. We found that the blood supply in the brain has already been affected and they are born already with the brain being impacted. So there are things that's impacting the brain that already there. As I said, the most consistent risks in all literature is maternal education and and socioeconomic class. These are constant, even when you account for all other factors and you do a univariate analysis. So this is one thing. Maternal mental health after birth is so important. It impacts, and that's why getting the maternal mental health um, right at first can impact positively on the child outcome. There was only one study in the Cochrane review showed by Spittle that there is impact up till 3 years of age of early developmental care on babies later on. But what we found is early intervention can stop the cycle of failure to learn. For example, if you have a baby who have visual spatial problem, but they are intelligent and their attention difficulty is quite short, and because of the stress they've been under, they don't have the executive function in middle childhood, which means multitasking is there. What will happen? This child will start in primary one. He will sit there and he will be next to a window and he will look out, and the teacher will ignore him because he's not disruptive, because a lot of these children are not disruptive. They are rather what we call internalizing. They are quiet. They are internalizing behavior. So what they will do, they will be ignored. And then they move from the big lines to the small lines. And then with visual perception, they can't learn. Or the teacher will ask them to multitask, do one, two, three things at the same time, and they cannot multitask because their brain is a premature brain, which we know that it's already, and all the research, we've got a professor in Edinburgh who does all the research on the brains, who worked with Professor David Walker in London, and they found that their connection is different between the thalamus and the prefrontal cortex, and all of these things, they need longer time to finish a task. So if you are not giving them longer time to finish the task, they lose out on the task. And then they have accumulation of failure. They are very sensitive children. So what they do, they feel, oh, I haven't learned. Why can't I learn? I am stupid. So they will withdraw more, become more anxious, and go into depression. Why I'm saying that it makes a difference, I was speaking to one of our FYs, MTS, and I didn't know it was I organized a conference in the Royal College in 2014 to increase awareness about educational needs of children born preterm. So I was telling her about it. And she said to me, oh, I was born at 28 weeks gestation. And I'm a twin and my sister's a teacher, but my mom was so good. And I didn't know, I thought it's only me. I had every problem you just told me about. But what, and she said, when we moved from the big line to the small line, I couldn't read first. And I thought, am I stupid? Mom gave me extra tutorial in math. She gave me time out. I taught myself how to multitask. So there are things that we can do to improve outcome. And that's why I'm so keen that people know early. so they don't have accumulation of failure. I was giving a talk about 7 years ago about the subject educational needs of children born preterm to physiotherapists, and a physiotherapist said to me, oh, my boy was born at 34 weeks gestation and he couldn't do numbers. So I sat next to him and I found it's a crowdness problem. He takes one line from one problem and then the second line from another problem. So I got a ruler, I put it under every line, and he started getting A in math, and he was 16 then, and he was going into university. So there are things you can't change, but you can modify. And there are children with whatever early intervention you will do, you might not be able to modify. I hope this is answer your question.
Thank you, doctor. Now, another question, please. What is the early signs for deviation from the normal neurodevelopment? How I get that this baby, either in NICU or in the follow-up visits, okay, he is deviated from normal. Is there any screening tool?
Professor Afaf, do you want to take it or you would like
لا
me to take?
I will let you دكتور نشوى يعني it's your you are professional in this
So the first thing I see in these babies is poor feeding and aversiveness. So if they are, first thing I see, and this is actually a lot of research found that babies who are going home oral feeding, they have a better outcome neurodevelopmentally. Okay. They are not organized. Their eyes are all over the place and they have negative touch. So that's the first thing I see that I would know that we need to work on. So it depends on what you are looking at. So learning difficulties are impacting also your motor difficulty. So you will find that they are not children with not cerebral palsy, but learning difficulty, sensory problems, autistic-like behavior will start by being not able to control their head, being floppy, and this is part of their proprioception as well, and your sensory integration. And um, so they are actually not organized. They don't know how to calm themselves down. They cry and you cannot calm themselves down. So you touch them and they are all over the place. So that's children with sensory difficulty and with going to have some problems that some of them we can work with and some is going to be learning difficulty. That's I see a lot. Cerebral palsy, it will be persistent motor, persistent reflexes, and probably if you are doing surveillance, it will be the right and the left is not the same. So you have say mom say he's using more the right hand or he's using the left hand more. But I can tell you that with strokes, even before the research that's produced from Newcastle, us and the physiotherapist, we used to ask the parents to stimulate the arm that expected to be weaker, and what a difference it make. I learned this actually from our orthopedic surgeon who deals with Erb's palsy. She was giving a teaching, and I used to say to the SHOs and the registrars, if you have a child on the postnatal ward with Erb's palsy, what do? You ask them to do these exercises, everything again is, so you do the opposite action to your Erb's palsy. And when she came to give the talk, she said, no, we will do this with the occupational therapist and the physiotherapist. What I want you to say is for the mother to touch the arm, which makes sense. If you have a baby with congenital cataract that's ignored, you get cerebral visual impairment. So if you have a weaker arm and you are not touching it, or a baby left in an incubator without not touching it, we don't know the impact of the perception of the brain to this limb. And I can tell you, over the last 4 years, I've seen so many babies who are still, there is weakness, you are not taking it away, but they are functional with the hand because the parents have stimulated it. And they support the good hand with the weak hand if they want to do a bilateral movement. So it's so important that you touch these. So I would say if it's motor, sometimes they are very alert and aware, but you will have difference between right and left, or you will have, as I said, you will have neurological problem or persistent primitive reflexes, like if you have persistent moro after 6 months, or they have very strong ATNR that's very specific to dystonia of dystonic CP. If you have learning difficulty, I feel most of them have low tone and they just poor head control, they arch their back, and they are very low toned. And that's reflecting sensory and learning. So, do you want to add anything, Professor Afaf?
Um, no, thank you, Dr. Renasha. But I think that also the nutrition of the mothers affected much the brain development of the baby.
Oh, yeah.
I think that even the iron, of course, the macro and micronutrients and vitamins, but we studied that iron itself. It the main micronutrient present in the brain, in the neuron, in the synapses, in the hippocampus and amygdala, and the brain stem. So the iron, this is just one example of micronutrient. So we know that that even the RBCs usually have attracted to the hemoglobin. The RBC, the iron is attracted to the RBCs and not attracted to the brain. So usually when there is anemia, there is called a delayed anemia, or it's called the brain anemia. So the brain anemia is coming first than the blood anemia, and usually we don't know how to measure this brain anemia. Always these babies with brain anemia, without overt anemia, without a lab anemia, these babies have the same as you said, Dr. Nashwa. They usually have exaggerated reflexes, usually have restless leg syndrome. They have low cognitive function, or it's not mentally retarded, but they slow in thinking, because the iron is one component of the myelin sheath, and the myelination is very important for the excess of thinking and excess of the impulses. So even these babies, we have to see the nutrition of the mother. So I think that genetics, nutrition, immunology, and the immunity of the mother can affect the offspring, and can cause this abnormality in something we usually misleading, because usually when we see a child with exaggerated reflexes without any motor changes, we usually said, oh, there is it is easily elicited, but we don't know that easily elicited reflexes could be something happen in the intrauterine life in the brain.
That's true. Actually, it's one of the first thing that we do for children with global developmental delay. I mean, delayed in two aspects of their development or more, is serum ferritin and full blood count.
Yeah. serum ferritin also يعني coming يمكن cord ferritin started to be the screening, because it's not the actual
That's true. That's
the
true. Absolutely. It's
of
just easier to measure.
They started to think about the CSF citrate and pyruvate and so on, as something which is very hard to do it.
Yeah, exactly.
So we have many things affecting the brain development in the neonate, actually. Do you have anything else?
Excuse me, Dr. Nashwa, can I ask a question, please?
Sure.
I'm Asma Sadiq. I'd just like to ask about what do you think of the neurobehavioral assessment scale as an early detector, the Brazelton scale? Can it be used for early detection of neurodevelopmental outcome or delays in newborn post-natal discharge? Is it practical?
Absolutely. The problem with the Brazelton, it's cost a lot of money
Mhm.
and it's time consumption. So I was looking for something for our nurses in 2003 and 4, and it was 350 sterling pound to train one nurse, and you have to go to Cambridge. The trainer actually of UK is a friend of mine,
Yes.
and she was with me on the nice guideline, and she came and stayed actually here, so we are friends. And I know that it works. The problem is we have to work with what we have. That's
Yes,
why
yes,
when the Royal
Available
College
concept.
did something called Child in Mind, that's why I say just we have to teach the nurses to look at the behavior of the child, and we have to teach the mother to look at the behavior of the child, and
Mhm.
it will. Of course, all of these things have been tried and tested and validated, but and if you have the facility to do it, do it, and it's very good. But
Thank
as
you.
I said,
Uh,
you have to work with what you have. Thank you.
Okay. Thank you, Dr.
Dr.
Nashwa. Thank you.
Asma, Dr. Asma, before you leave, please identify yourself to Dr. Nashwa.
Dr. Nashwa, I am a neurologist and IBCLC, and I studied already the Brazelton, but in Cambridge, yes. So I was asking about the application. I don't find it applicable, or do you find it applicable or useful, according to your experience? That's why I was asking. I already studied it, but I did not apply it. But what about your experience in applying it? That's the point
Yeah.
of my question.
What I would advise, I mean, it's a pleasure to meet you, Asma,
Thank
and
you. Thank you,
I
Dr.
think I think use what you have useful from it. I'll tell you something. I how I knew the trainer, for example, I did with her maybe 20 years ago. I did the practicals with her, the general movement of the newborn. I did the advanced and the basic, and then the advanced was in Cambridge as well, and then in London. And I found I tried to video look at every baby. It's impossible that I video them and screen the videos and cut them into three parts. So what I did in my clinic, I look at fidgety movement, which is something in the advanced practical, and I adjusted this and I recorded to myself. So I took parts of it that's useful to my practice that I can use.
Thank you.
So
Thank you.
Brazelton work, but there are other things that work. I don't use it I don't use Brazelton. I don't have the time, and we didn't train the nurses. But what I do, I go around to show the mothers and the people, and I teach in all the neonatal nurse courses and the postgraduate certificate of pediatrics in Glasgow. And we teach what we call child in mind, about promoting positive relationship, the competency of the newborn, and you have to individualize your practice, and I think it's a skill you will never lose, so it's wonderful that you've had it. And
Thank you.
although Betty would say that she can adapt it to preterm now, but it was meant for term babies when it was produced.
Yes. Okay. Thank you, Dr. Nashia. Thank you.
You're
It was a
welcome. Nice
pleasure
to meet
meeting you. And thank you, Dr. Afaf, for this chance, for a great chance. Thank you.
You're welcome.
Okay, Dr. Nashwa, another question. Okay. According to our discussion, neonatal screening for developmental delay or developmental deviation is mainly clinical. When we ask for investigation, when
Okay.
it is important to do MRI, transfontanel ultrasound, when these neuro investigation are required.
So ultrasound is done routinely because it guides you, and we have a protocol for when it's done, but you have to do it at 36 weeks term as well to look at ultrasound. We know that research showed that MRI is far more superior to ultrasound. Even in UK, we cannot do an MRI on every baby. We don't use CT scans because of the radiation risk, it's very high. MRI, I will use the European Association for Cerebral Palsy would recommend any sign of early evolving motor disorder, you get an MRI brain. I was just seeing a child this morning in clinic, which I feel that her motor disability and arching and everything, it could be learning, not not but her neurology is not quite right. So I had to balance. Should I put her now through an MRI or examine her again after 2 months? So there is no, it doesn't change what you are doing, because you are looking at the child and working with them. I know in practice in Egypt, people will come back and say to you, oh, you've missed that. That's why you have to do the investigations early. And that's the pressure on you. Here, I'm honest with the parents. I told them I'm worried about this neurology. We'll have it in 2 months' time at the MRI. Still, the baby will be tiny and we can do it. So an MRI of very useful, but actually it's the functional MRIs with the fusion tensor imaging that's showing you the connections. But we don't have functional MRI in UK except for research, and that's very expensive. And or MRS, where you are looking at the lactate peaks and all of these for hypoxia or impact. So for me, investigations is a guidance, and in case I'm missing something, the neuro investigation. So if you think maybe there is something else in this child that we are not sure, and that's when you do definitely an MRI if you have the facility and the money to do it. If you have a baby who is not clear why the developmental delay is 4, so he's delayed in 2 out of aspects of development, say delayed in walking, plus delayed in learning or in speech or in communication or play. And play is usually the sign for a lot of the children we see that are very, very basic play rather than functional interaction. We can do more investigation. This includes thyroid function test, basic stuff, iron deficiency. You will look at basic biochemistry, and then you go to genetics. And the basic genetics will be, you can do your karyotype, or you have microarray. Microarray will show you the karyotype. And we do a lot of Fragile X syndrome as well. We look for it because these children present, a lot of them with, some of them with autism like to excluded. If you have a lot of consanguinity and parents are first cousins, you could think of metabolic. So you can do your organic acids in the urine, or amino acids, or ammonia, but ammonia is not very stable. So sometimes you do your uric acid in the blood. So that's what we will do. So I think I always think, how is the investigation is going to impact on this child? And will I put him, if the baby is young enough, we can feed and sleep and do the MRI. If the baby is a bit older, we can give melatonin and do the MRI. If I have to put them through anesthetic, I don't know how useful it is. If there is clear cerebral palsy, I will do it. If there is regression, definitely I will do MRI and EEG. That's very important if there is regression, because that's a very, very red flag.
A sign of inborn metabolism or neurodegenerative disease if there is a regression, I think. What do you think, Dr. Nashwa?
Okay, the red flags. Okay, the red flags in general, in infancy, discrepancy between right and left.
Mm-hmm.
Baby not fixing or following by 6 weeks.
Mm-hmm.
An infant not sitting by 8 months independently. 8 or 9 months by 9 months. A child is not walking by 18 months. They consider it red flag. A child not communicating at 3 years of age. So these are considered the surveillance of the red flags. But I would like to add to these red flags is maternal concerns. And then, as I mentioned, regression is one of the things. So asymmetry, regression of skills are really concerning. And I don't know if you want to add anything, Professor Afef.
No, I think these are the reflexes. Of course, the delayed head support first in the turning on the abdomen or not.
Absolutely, at any age.
All
Yeah.
reflect from the start from the 3 months of age.
That's right. Thank you very much for reminding me. Yeah, so tone, absolutely. Floppy or harsh, that's at any age, that's really worrying. I don't rely always on tone, because if you go from floppy, because a lot of children with cerebral palsy babies develop, they might see you during a normal tone, which they are converting into high tone. So when you are looking at a baby, all babies will have a degree of head lag. They bring it up to midline and then they flop. And you have to differentiate between, are they weak or are they low tone? Because is it central or peripheral? So a central hypotonia coming from chromosomes or brain, a lot of them have facial expressions, like children with HIE, they will have facial expressions and they have anti-gravity movement. If it's coming from spinal muscular problem or a muscle like your SMA, or the child will be weak, which means they will have no facial expression and they don't have much anti-gravity movement. So that's, you can differentiate between central and peripheral hypotonia to guide you to what investigations. Of course, if a baby is born like this, first thing you have to look at infection, nutrition, metabolic. These are the first things that you look at, and then you proceed to higher investigations.
We usually combine the weakness, especially the prefer from the center, that the tone is present in the peripheral and not present, or it's the reflexes. It's hyporeflexia.
That's right.
And
right.
hyperreflexia in the center. There's
right.
hypotonia with hyperreflexia in the center.
That's right. So weakness with hyporeflexia, or low tone with present reflexes, and they have a movement anti-gravity. Absolutely. Thank you.
Are there any other questions? Because
your questions are excellent, guys. Excellent.
We are pleased and glad that we have Dr. Nashwa with us. So it's a very good opportunity to ask, and she's willing to answer every question. Is there any question in the chat box or QA? Okay. So, okay, Dr. Marwa, you have to close the session.
We are very thanks for Dr. Nashwa, for Dr. Afaf, for this interesting and very informative talks. We get very much information. We
hope
want to another
that we have to repeat our meetings every now and then
for another session regarding the area of neurodevelopment.
Neurodevelopment, yes.
We thank
you very much. It's my pleasure to meet you, and thank you for inviting me.
ميرسي يا دكتورة نشوى. شكرا وان شاء الله نتقابل تاني في مواضيع كتيرة تانية. اكيد بينا في مواضيع كتيرة يعني مهمة لكل الجنريشن.